Welcome. I'm Dr. Lisa Toppin, and you are listening to Inputs to Action. This episode, we are pleased to present Laura Crandon, founder of Touch for Life, a nonprofit focused on and committed to breast health equity. So, this is an incredibly important conversation. And Laura, I'm so glad you're here. Thank you.
Thank you so much for having me. It's my pleasure.
This is an important conversation, and we've got to just dig into it for our listeners because health equity, particularly as it relates to women's health, so important. So let's start with your background. Let's start with who is Laura Crandon and how did you come to this work?
Yeah, so I've been a health plan executive for 15 years. And prior to that, I had my own business. I'm also a venture capitalist. So I've had a really varied background, which has brought me to this. How I got here is in 2016, I had a mammogram, like many of us do. It said dense breasts. And what I know now, but didn't know then, was that dense breast is a risk factor. And even though I was a health plan executive, being a Black woman, like 50% of Black women, I was not referred for additional screening, an ultrasound, or an MRI. Until 5 months later, thankfully, I was doing my own self-exam and found a lump that ended up being cancerous, which led me to chemotherapy, surgery, radiation, and targeted therapy for a year after that. And I was declared no evidence of disease, which was great for a year. But in fact, it came back and metastasized to my brain. And as I was going through my journey, as I talked to many women, Black and brown women, I realized that we just don't know the risk factors. We aren't aware of what we should be doing. And in fact, there are disparities. We die at a 41% higher rate than other women. We are diagnosed under the age of 35 with an aggressive form of breast cancer called triple negative breast cancer. And we die at a higher rate at that young age. And so the standards of care that are set don't work for us. Oftentimes the medication doesn't work for us. And so I decided to do something about it and found Touch for Life. That really comes from my commitment to service that I grew up with my parents. My mom was a hidden figure in NIH and faced some blistering racism, but continued to persevere and then open the door for others. And my dad was a Negro League baseball player and similarly opened doors for others. I saw that all my life. And so I decided that this journey was my journey, and I was going to open the door and help break down the barriers of inequity around breast health.
Well, we are grateful for your service and your commitment to this space because, as you point out, in the statistic that you raise are staggering, and clearly we need much more attention on what's happening and what we should be doing. So I know that you'll lead us through there through this. What do you think is the biggest gap for women of color in the current system? So that the you know it- why is it happening the way that it's happening?
That's a wonderful question. I would like to dispel something that comes up quite often, that this disparity is driven solely by what's called social determinants of health, barriers like transportation, insurance coverage, and access. What the data bear out, however, is controlling for those factors. There are still gaps and disparities in prescribing patterns, treatment, and outcomes. Meaning that if I walk in the door and someone else walks in the door, although a standard of care might say, and standard of care is basically what physicians go by, if it says that I should have, let's say, genetic testing or what's called, genomic testing on my tumor, that that is not performed on me, but it is performed on someone else.
Yeah.
So that's some of the root cause of the disparity is, in fact, treatment patterns. And when those things aren't prescribed, when the therapies come out, so the prescription drugs that are targeted precision oncology, we often will get left out of that equation.
Yeah.
I'm not saying that social determinants aren't a factor. It's just
Sure.
that that's not, the only
Only
factor.
thing. Right. And I think, and I think that's just an important point because that's where we all leap to. So everybody's trying to figure out how do we reduce the distance between, and how do we reduce the distance between care, or how do we reduce the things that keep people from getting to care. But what you're suggesting, and I think is true, and I think we probably each have our own story and testimony around this to some degree, is when you don't always treat you the same. It is really at the practitioner level in which some of these gaps show up, and we've got to deal with that. And that's a real thing, not different than what you might find in the workplace. It's the same kinds of things that are happening. In this case, it's happening in healthcare. So I think this is the right conversation. Like, we've got to start pulling this apart and talking about it, because the only way we're really going to get to the precision medicine that you mentioned, which is the path we're on and the path we want to obtain, is really how do we make this better, and what's keeping us from even the great science that we already have available. What's in our way? So when as you put that on the table, what do you think providers could do today to close some of this gap? What could we be doing now?
One of the things that Touch for Life does, in addition to working in the community, is making the rounds across the country and speaking to physicians and putting a face to what the disparity looks like, and frankly challenging them to be equitable and in their treatment, in their ordering patterns, and in their inclusion in clinical trials and testing. And oftentimes I ask them to think back to the last 10 patients that they treated, and with the same condition. Did they have the same recommendation for treatment?
Mm-hmm.
Look back at your last 10 patients that you referred to clinical trials. What did they look like?
Mm-hmm.
The last 10 patients that you referred for testing, what did they look like? Just as a gut check.
Mm-hmm.
Because I don't think any physician goes in and says, I'm going to kill Laura Crandon today.
Right. No, they don't.
They went into this profession, and I asked them in the beginning to always think back to why they got into this profession. It's a mother, a father, an aunt, a coworker, a classmate, and they wanted to change the world around cancer.
Yep.
And so I believe it's with good intent. I believe there are just some structural things in place and some biases in place that they have to check and challenge and go through the training. And it's a gut check and it's a data check that they can do, frankly, because everyone can look back over their panel of patients and see, what did I?
Right.
And I think there's some studies that show that physicians are surprised. They really believe they've done these things.
Right.
And you pull the EMR and it doesn't happen. Again, I don't think it's intentional. I don't think there's any malintent. But that's also why we educate the patient to make sure that they're asking questions about their own care. And so it's a two-way street of shared decision-making and a good dialogue to have.
Well, it just like this dialogue is so important to have, because again, you're sort of equipping physicians to think about what have you done, and is it your intention, or is it actually your impact that you're pleased about. But you're also saying, and I think this really sort of leads to the question I was going to ask you, but you're sort of hitting on, is what should women be doing to close this gap? Like how do we take the empowerment ourselves?
Well, that's one of the things that we are focused on as well at Touch for Life, is getting out into the community where people are, meeting people where they are. And that's working through our community partners, whether that's the Divine Nine, sororities and fraternities, or other organizations like Jack and Jill of America, we're working to get the word out about what your risk factors are, the things that you should be doing. And I'll go through a few of those. One, and the number one, is what is your family health history?
Mm,
Oftentimes we don't know what Uncle Joe, had until gets his foot amputated, or,
right.
he's in the hospital. But what's really important to know what your risk factors are is your family history. And I know these can be tough questions. I know that our families are really different. It
Mhm.
really does help determine your risk factors and how often, how early, and what you should be doing with your health. I'll just give you an example.
Mm,
And you remember that you inherit your DNA from, half and half, mother and father. So it's on both sides.
mhm,
So let's say a grandfather had prostate cancer on one side, and a grandmother had ovarian cancer on one side. That's a risk factor for you. So knowing that,
mhm,
then sharing that information with your physician might mean that you, even though the standard might say get a mammogram at age 40, you might need to get it at half the age that your grandmother got ovarian cancer. Maybe that's 25 for you.
mm,
Maybe that's 30. It also might mean that you need genetic testing to see if you inherited any of those genes that are called, mutations that predispose you or put you at a higher risk for getting ovarian or breast cancer if you're a woman. And then if you're a man and your mom or grandmother or aunt has had breast cancer or ovarian cancer, you could be at risk for prostate,
mhm.
pancreatic cancer. These things could run in families.
Yes.
And that's the number one thing, is to document your family history and have a conversation with your doctor about your history, because that makes you eligible for additional services and additional monitoring. Not meaning something will happen, but let's get out in front of it. And maybe there's some steps you could take to lower your risk of
Mhm.
ever getting one of these conditions.
Right.
Your siblings, your children.
Right, right. Well, you're raising all the right points, because even as you're thinking about it, like my mother, I might have shared with you, had three bouts of breast cancer, and so she had two lumpectomies and a mastectomy, and so I would be very intentional to share that with my daughter. But you just got me thinking. Well, you know what? My son needs to know too, and
Yes,
so.
he does.
Right. And so, just in terms of sort of really starting to think about what the implications are, how do you talk about the family history? And of course, you've got we got to hurdle some cultural issues. Like you said, we didn't know what even Uncle Joe was suffering with until they had to say, because now he doesn't have a foot. And so now we've got to talk about that. Whereas otherwise we might not. But I think your message here is that we've got to find a way in these conversations, whether there's a missing limb or not. Before there's a missing limb, we got to talk about all of these things. Um, do you think there's a role for allies in this, or what's your take on that?
I think there's a role for allies for sure. It's interesting because one of my former coworkers at United Health sent me an article, um, there was a webcast going on about health equity that she wanted me to be aware of. She's also gathering former colleagues to sponsor a scholarship for a Black physician. She wants to do. She sees the inequities and saw it laid bare with COVID-19 and wants to do something about it. So she's gathering a lot of United Health alum to, in fact, design a scholarship to sponsor. She's also looking at early STEM education. These are things that allies can do with resources, with networks. They can also help support organizations like ours. They could show up and volunteer.
Mhm.
And frankly, they can step in if they observe anything that's going on that appears inequitable, to use their voice and speak up to make sure that there's an intervention there.
Yeah. Well, no, and I probably shared with you that when my mother was going through breast cancer the first time and getting that lumpectomy, that was early in the days of lumpectomy as a procedure. And so My father, having done a ton of reading, was really her ally in helping her find the right doctor to do who believed in lumpectomy and was willing to do it. They were the doctor that she initially was working with really didn't believe in that procedure, and so my father's thought was he's gonna take more than he needs to. It's going to be more of a mastectomy, lumpectomy than just a so just the role of our friends, our families, just showing up with us in that process should we find ourselves there, I think is another piece to call out. So I'm appreciating this. Okay, so we've been talking about the steps you can take beyond beyond the standard screening and asking for that and knowing your family history that you might need that. Um, I think an important piece. How do you know when you need additional screening, or how should we be thinking about the approach to screening beyond the I thought I was supposed to go at age 40 standard regimen?
Yeah, so that is challenging. I mean, that's the information that we're getting out. There's a guideline recommendation that came out recently by USPTF. I think I've got that acronym correctly. That lowered the mammography age from 50 to 40. That's a good step. It's a baby step, but like 3 paragraphs down, it says, but if you're Black, if you have a family history, you might be at higher risk. So it's getting that information out. And, in July of 2021, the American College of Radiology declared just being a Black woman means you're high risk, which means you probably should be seen by a high risk breast center in your area, if possible, because they've got more monitoring resources. They do the testing. But you also can do your self-exam. That's important because only you know what you look like. It's both looking and doing an exam by touch yourself. Touching your breasts and doing. Remember, your breast tissue is from your collarbone all the way through underneath your arm. So doing a thorough exam of that, and you're noticing something's not right and speaking up and saying something.
Yeah.
So yes, your physician, really having a conversation with your physician, what's called a risk assessment, sitting down at your next appointment saying, I'd like to understand what are my risks for certain conditions. And here's my history. Here's what I'm concerned about. Here's my lifestyle behavior. What does that put me at risk for? And having a conversation. And then, would it be wise for me to have genetic testing? And then we're talking a lot about prevention and risk factors, but also even when you're in the breast cancer journey, what's troubling is sometimes you're not getting the tests or standard of care that work for you. So making sure that you're ensuring that let's say you have breast cancer, your tumor tissue is diagnosed, that you've gotten a look at what kind of mutations, what's really kind of driving and promoting your particular type of cancer, because there are different paths you can take based on what's in that tumor, what's in there, and what's driving that.
So again, it sounds like really there's a opportunity for us to arm ourselves with the right questions, with the one, what our history is, and then with that, doctor.
Yes.
Okay. Oh, my screen went out. Okay. Terrence, I'm gonna need you to edit that. With that, doctor, what should I, what standard of care should I be following? What risk factors do I have? How should we be thinking about this for me, given my particular set of circumstances? So I think we're really setting the doctor up to be able to get more precise around what and how we should be treated.
Yes, and what's going to work? What do you think will work for? Will work for me? And even when the medications come out, because we're not in what's called the bio data, and scientists begin to take that bio data and look for causes of cancer, then the causes that drive cancer most prevalent in us aren't necessarily being discovered, and so the drug therapies that come out don't necessarily work on us the way that they should. And so a fair question is, how has this worked with your Black patients?
Right.
That's fair. I mean, I give an example of, I was on a particular medication, and my son, we were having a meal, and he looks over and says, "Mom, what's wrong with your hands?" And my hands are black. The bottom of my feet are black. And he's like, "I see black spots on your tongue." And I panicked. I thought I was going into liver failure.
Mm.
And no one had indicated this would happen to me. And I go back and read the side effects of the medication, and it says you may turn red. So you see me.
Right.
If Lupita Nyong'o turns red, if I turn red, like the world might be coming to an end.
Right.
And that just tells me that no one who was melanated like me was in the clinical trial.
Right.
And so it's also important to ask your doctor, is a clinical trial an option for me to get the latest science, to get monitored very closely. I was in a clinical trial. It helped save my life. And, is that an option for me? And unfortunately, I am putting a lot on the patient, but it's a balance, right? If the data show that we're not always getting standard of care, we are trying to educate the physicians in that way, but also to have a frank conversation with your physician. And like your parents did, it's okay to fire your doctor,
right.
To get, because it's your team. There's only one you.
Right.
So you want to have the team that's really team you, and who's really supportive of your care. So it's a dialogue.
It's a dialogue, and here's what I like about it, because even though we're sort of putting a lot of accountability on that patient, the physicians will come along. So even if they don't have it completely together for you, 5 patients later, guess what? They'll be better, because that's what practicing allows you to do. So the more of us that show up early and start helping our physicians think about this, the better they will be for our daughters and our sons, and for the rest of the community who are looking for that standard of care and that response that really responds to exactly what they need. So it's not there is hope in that. One teaches one, whoever the one is, but then then everybody does better as a result of that practice. So okay, so you mentioned dense breast, and I know that and that being something that Black women in particular are dealing with. Are there any other issues around the density of breast that we should be aware of, thinking about, and dealing with, other than the fact that it has implications for maybe deeper diagnostic or deeper screening?
Yeah. So just to remind the folks, because this is national, is that dense breasts, what that means is the radiologist can't see. And think about it as a forecast. On a there might be a plane in the sky. On a sunny day, you can see the plane. On a partly cloudy day, you can see part of the plane. You can make out it's a plane. On a cloudy day, you might see something, but can't really make it out. And then overcast, you can see nothing. And that's really how it is with dense breasts and potential cancer lurking in the back, like that plane. And so what you should know is the degree of density of your breast. I'm not going to get all nerdy on you. There's a term, called BI-RADS, that really tell you kind of the density, what are you in that forecast.
Okay.
And that helps you then make better decisions to say, well, gosh, if it's partly cloudy if it's cloudy or overcast, should I get additional screening? Should I get an MRI? Is there something else that might be able to tell a little bit better what's behind those clouds? And so, unfortunately, the disclosure of how dense your breasts are is a state-by-state statute. And so if you live in a state that requires it, fantastic. And more states are adopting it. And Touch for Life has a core team. We're building an advocacy core to advocate for legislation like this with our legislative bodies at the state level. But so if your state doesn't require it, you just get the the letter that says you have dense breasts, poof, that was me.
Okay.
You might not know what to do. So what's next is having a conversation, and or hopefully your physician is saying, gosh, let's take a second look at a deeper dive here.
Mm-hmm, mm-hmm, mm-hmm. That's really helpful. That's really helpful. Okay, so now you also when we spoke earlier, you shared about the lining, the cell lining, and its significance. So layperson audience here, but what is significant? Help us understand sort of the cell lining and its significance and what we need to know.
So when you talk about, I like to use the analogy of think of a hydrangea plant. It's a beautiful plant. Typically, the blossoms are pink, blue, sometimes purple. But think about the seed that it starts with. Remember, that seed comes from the male and female part of its parent, just like we do. And so it's inherited certain things that make it a hydrangea. No matter what, you put that seed in the ground, it's a hydrangea. It's born to be a hydrangea, like we are. And it's inherited the properties from its parent flower. That's us. That's our genetics. That's what we. And so you put that seed in the ground, and it grows. But how big it grows, how wide it is, what color, in fact, the blossoms are. Maybe it was meant to be all blue. That's based on environmental factors like the soil, the water, the sun, just like us. So there are things that are environmental factors that make us exposed to different things that might change what was originally intended to be, a blue hydrangea. And maybe all the blossoms on that plant are blue and there's one pink. And so that's called a mutation.
Mm-hmm.
And that needs to then be cut off and dissected and figured out, well, what made that blossom pink? Was it the soil pH? Was it didn't get too much sun, not enough sun? What's driving that? That's what happens when they take the tumor out and look inside of it and see what's driving it. And that way, from a precision perspective, oncology, they can say, oh, my goodness, it was too much sun on this side. So let me put some shade. Let me turn some things off, turn some things on. And that's what we do with the medication. We target certain things that are driving these what's called mutations.
Okay, excellent. Okay, all right. And again, so the one thing about going through a journey like this, you get really sophisticated about all of the facets of what this is. So I love how
I'm sorry, I probably nerded out a little bit too much on that.
Completely educating us, but your analogies are perfect because I'm completely following you, even though I did get a D in botany. But we're going to move on from there. Okay, so now.
I'm right behind you in physics.
Oh man. Okay. Yeah. So you feel my pain. So clearly what you've outlined here, there's a role for researchers, for providers, for Black women and everybody else. So one of the things
cell lines too. I'm sorry, I should also talk about, for the cell lines perspective, there are researchers that do basic science that talk about when they're looking to discover drivers of cancer, and they pull certain cell lines, like in the petri dish. They're seeing that there's some differences in the cells that drive Black women's breast cancer and other women's breast cancer. And so there are differences, which is so important for us to participate in research,
right?
Any kind of research, because it is my fundamental belief that solving this challenge for the Black woman, particularly given our history in the United States, that we have a little bit of a lot in us, that solving it for us is going to solve it for everybody. And so they're seeing that there's some differences. And so it's important to really, again, I think, ask your physician about, how does this work in your panel of patients, and how might this work for me as a Black woman?
Yeah, no, that's so good. No, we've got to be empowered here. So what are ways then listeners can support your organization, and how does your organization fund its work? Because it's so important that we're getting this word out.
Thank you so much. So, Touch for Life, thankfully, is funded by supporters, individuals, foundations, and corporations. And so we are grateful for that support to keep our programs going. Our programs include a monthly webinar called SOS, Soul Filling Our Sisters, where we have experts from around the country available for people to ask questions about mental, physical, and spiritual, social well-being. We have sessions like on menopause. We have sessions on healthy eating. We do programming. For example, it's Be Fresh. And FRESH is an acronym. It stands for Food Restores, Energizes, and Sustains Health, where we have workshops by certified dietitians and nutritionists and fitness experts to talk to people about, our community, women of color, about the importance of food as medicine, which helps sustain us, help boost immune system, energy, and of course, avoid certain conditions. So that's Be Fresh. We also, through Be Fresh, have a program with a community organization, Alpha Kappa Alpha, where members are growing fresh produce and then donating their harvest to metastatic breast cancer patients. And lastly, we have a great program, Black Genes Matter, where we come out and talk to organizations. We kick it off with a party with a purpose. Wear your Black jeans, learn about your Black genes. But then we have a whole curriculum talking to people about the importance of understanding their health history, the role that genetics and genomics plays in their risk factors and treatment, what they can do, and that is our program for the community.
Wow, that's wonderful. You've got so many touch points and so much education built in. So that's phenomenal.
We're always looking for folks to support us. So it's touchforlife.org, touch the number 4, life.org, if you're inclined to support and make a contribution towards our programming.
Okay, so this has been a phenomenal conversation, and one of the things we always close with is getting your advice. So you have given us great input, and now it's time to crystallize on an action or action. So what should we do? So you've outlined researchers, you've outlined the role for providers, and you certainly sort of empowered us to understand our role in taking charge of our healthcare. So all of that, really great. But what else should we go do?
I can think of 2 things. One is begin to have your first conversation with your relatives. Grandma, Pop, I want to live a long, quality life. And I've inherited a lot of good things from you. I want to know all the things I inherited from you. And one of the things that's going to help me live healthy and to know what to do is to know what conditions that might impact me. And I'd just like to have the conversation with you and tell me, because it's going to help me in the long run and help my children and the rest of our family as a legacy. So making that accessible is one thing, having that conversation. The other thing is, certainly if there's information that you've liked that I've presented, or you want to know more, Touch for Life works with community organizations. If you've got employees that need to know, you've got a community group, a faith-based group, and you want Touch for Life to come out and give a workshop, we're happy to do that. Participate in your health fair, we're happy to do that, because this information needs to get out to as many people as possible. So don't be a reservoir, be a river. Don't just take the information that you've learned here today and take it for yourself, but share it with someone else. Give life to someone else by making it flow like a river.
Ooh, Laura, I love that analogy. What a great way to bring close to our conversation. Be a river. I love it. Thank you. Listen, thank you for sharing so much of yourself in this conversation. So impactful, so important, and right in the lane of where we want to be. We've got to get better about making health equitable and accessible to others. And part of it is just how do we understand what do we understand, and how do we leverage that for our care right now today. Audience, thank you for taking some time with us. I want to thank Laura, and I hope you'll reach out to her at touchforlife.org. I'm Dr. Lisa Toppin, and this has been Inputs to Action, and I will see you next time. Thank you.